Welcome to pharmacokinetics of oral absorption. The learning objectives are to discuss the two general approaches used for studying absorption kinetics and their similarities and differences. And of course, those will be covered in the very beginning of the lecture. Understand the basic principles for physiologically based absorption kinetics. So that second bullet really gets into something that we're not going to spend a lot of time on because the equations are much more complicated. So a lot of that is going to be left up to the software that's out there. So for that second bullet, I just want you to understand the general advantages of physiologically based absorption kinetics in those models associated with that. Describe the oral one-compartment model and explain how this model simulates drug absorption from the gastrointestinal tract. Calculate the pharmacokinetic parameters of a drug that follows the oral one-compartment model. So as you can see, we're not going to get into the two-compartment models with oral absorption because the equations get much more sophisticated as we do that when we combine absorption with multiple compartments. Discuss how the absorption rate constant, or Ka, and the elimination rate constant, or KEL, may influence Cmax, Tmax, and area under the curve. So just an introduction here. A drug is technically considered absorbed when it leaves the GI lumen and it crosses the epithelial cells of the GI tract. So just to clarify, the FDA considers absorption when the drug leaves the GI tract and crosses the gastrointestinal epithelial cells. So that absorption technically is, it's not yet in the systemic bloodstream at that point. It's actually going to be technically in the portal vein or the capillaries in the GI tract. So whether or not something gets to the systemic circulation, that also depends on the first pass metabolism. So absorption technically occurs prior to first pass metabolism. This lecture will cover the kinetics of absorption rather than the physiology and biopharmaceutics. We already talked about the physiology of absorption. We already talked about biopharmaceutics. We're going to talk about the actual math, some of the math that can be done to model absorption, and then the subsequent blood concentration time curve after absorption as well. Now, kinetics of absorption can be studied by a top-down approach, and this is what we're going to be looking at for the most part. You're looking at actual blood level data, so plasma level versus time data, clinical data. You look at that first, and then you make conclusions about absorption. Okay, so that's typically compartment modeling. Alternatively, there's a bottom-up approach, which means starting with nitty-gritty details about each organ system, or at least each mechanism of absorption, right? So basically, you can quantify those individually, so diffusion, transport, quantifying each mechanism of absorption, and then making a model based on those individual contributions. We're not going to cover that in great depth because that's not used as often. Okay, typically you're looking at plasma level data and then you're making the model from that. But regardless, the main goal or overarching goal is always to be able to predict the plasma concentration in the patient at any given time and be able to calculate dosing to achieve the desired concentration. Okay, so any model that we have, just remember the main purpose is so we can make extrapolations or predictions and say, well, even for data that we did not generate, right, or for time points that we did not assess, right, can we still make a prediction about the plasma concentration? And that's the main point. And the reason why it's important is because it helps in choosing the dose that they're going to use in a clinical study, for example, a clinical trial, things like that. So we're first going to talk about this bottom-up or physiologically based absorption kinetics modeling. This was in your learning objectives, and remember I said I'm going to cover this very briefly because it's a lot more complicated. My only purpose in showing this is to let everyone kind of get an understanding of how detailed we've gotten, and in terms of the software that's out there, how many different factors you can include in the software. If you end up working at the FDA or end up working for a drug company, if you actually ended up furthering your education in pharmacokinetics, you might see more of these. But the examples, if we had, again, if we had data on individual transporters that are relevant to drug absorption in the GI tract, and all this, any kind of specific constants that we can generate for that drug on a tissue-based level, we can use this. And actually, it's not really just about absorption. We can use physiologically based modeling for elimination as well, and distribution. And all that it means is that you're taking the physiology of each tissue and including the math behind that, the constants behind that, and incorporating it into a large equation or model. So the main advantage of the physiologically based absorption kinetics is that we can extrapolate data from one population to another, unrelated population basically, as long as we know each parameter in the absorption process. That means if I have, for example, if I know in a healthy population, let's go back to our example. We talked about metformin and how it requires transporters to be absorbed. If I knew that one population of patients had abnormal transport or slow transport, if I had a model that included that transporter activity, then I can modify that in the software, and then that can give me a new prediction on the absorption kinetics. You couldn't do that if you didn't know anything about the transporters and you just had plasma level data. So this physiologically based absorption kinetic modeling, or any physiologically based pharmacokinetic modeling in general, has that advantage. The main disadvantage is you have to generate all that data ahead of time on each component of the process. Okay, so generally no one's doing that calculation by hand, so it's going to require software. So examples of parameters that are used in physiologically based absorption kinetic calculations would include gastrointestinal transit times. Okay, if you knew from patient to patient or population to population, they had different gastrointestinal transit times, you can include that in the equation. pH of each portion of the GI tract, if you determine the relevance of the pH to drug absorption, then you can include that in the equation. Diameter, surface area, and other geometry of the GI tract. And in the software that I briefly mentioned that I now have access to, and any one of you have access if you're interested, called Gastro Plus, that allows you to change the geometry of someone's intestines, in this hypothetical population of patients, and see how that affects absorption. So that'd be an example of physiologically based pharmacokinetic modeling. Okay, and that's what I just mentioned. The last bullet there, that's what I was talking about. Gastro Plus, you could change anything. You could change things like pH, the volume of fluid in the duodenum and the jejunum, the length or diameter of the duodenum, jejunum, and all that stuff, and then you could actually get a prediction about how the drug absorption would change. Again, not everyone is using this level of detail when they're predicting oral absorption kinetics. So you'll see on the next slide, the arrows in the image represent drug movement. Okay, and I just want to prepare you for understanding what this slide means and what all the graphics mean. Each arrow will have a rate constant associated with it, just like the compartments we already talked about. But instead of large, like 1 or 2 compartments, we're talking about many small compartments that have their own rate constants. If we combine all constants into an equation, we can predict the rate and extent of drug absorption. Okay, now we know, starting off in the 1990s, they started, probably late 90s, they started to learn about these transporters, drug transporters, and started to clone them so we could characterize each one individually. And now, because we've characterized individual drug transporters in the intestine and in other organs, we can add those to these pharmacokinetic models to account for their contribution. Some of them contribute to absorption, some of them work against absorption. For example, you can generate a model that has P glycoprotein or MDR1, and remember that transporter pumps drugs out of the intestinal cells and back into the lumen off the apical membrane. So that would actually, the more activity there of PGP, the less absorption. The one place where these physiologically based models would be really ideal is if you're looking at pharmacogenomics, because you know, the large compartment models that we're going to talk about for the most part, or those top-down approaches, they're really not equipped to deal with pharmacogenomics, because you can't incorporate individual proteins into the equation that have been mutated and have lower or higher activity levels. So again, this is why I didn't want to hold you responsible for anything with, you know, equations related to this, because every single one of these arrows can be will have a constant associated with it, and you can have a very complicated equation that incorporates everything here. And all this is showing you is that it's a little kind of confusing, but so imagine someone is ingesting a drug, it goes into the GI tract. If we zoom in on the GI tract, we have all the way from the beginning to the end, stomach all the way to the ascending colon, and even beyond that. But the ones that are in this model, you can see, are the main absorption sites, which really, as we know, are probably definitely the jejunum, a little bit of the duodenum, jejunum, a little bit of ileum does the drug absorption. So what this looks like is that, so if you have unreleased drug, for example, drug that is not dissolved yet, it's unreleased from the dosage form, it will move to the next compartment, and that has a kinetic constant associated with it, just like everything else does. If it does get dissolved, okay, or actually this is released, that means the particles are released from the dosage form, like the tablet. If it does get released into particles, then it can get possibly dissolved. If it gets dissolved, it'll move to the next phase. If it doesn't get dissolved, it'll move again to another. What I mean by that, by the next phase, is that if it's still in the stomach, and let's back up a step and try to make sense out of this. Just imagine we're only in the stomach. We have a drug, starts off as a tablet. If it breaks apart, some of it will be in the undissolved phase. At that point, if it gets dissolved, then it'll be in the dissolved phase, and then it might get into the, it's saying enterocyte. In the stomach, it's really a gastric cell, but they're saying that the only way it's getting into the cells is if it finally gets dissolved. At any step here, if that doesn't get dissolved and then absorbed, it could move to the next compartment, or then we'll say the next piece of the GI tract. But every one of these arrows has a constant associated with it, a kinetic constant. Okay, and we can, you know, like I said, that program Gastro Plus and many other programs out there are at this level of detail, right? So it's incorporating the pH of each compartment, the length of each compartment, and when I say compartment right now, I just mean the different components or different segments of the GI tract. The pKa of the drug, so the lipophilicity of the drug, all that is incorporated into the equations now. Okay, so some of the data that you would get from one of these programs might look like this. For example, if you're using the program Gastro Plus, and we have a drug Lasix or furosemide, a lot of this stuff is already preloaded into these programs. The pKa of the drug, how soluble is it? In this example, it must have a patient population that have multiple doses, so dose number, and then I don't know what all these mean, but the whole point is that it's going to generate a lot of predictions for you. The solubility at different pHs for the drug. Log D is basically like log P. It's very similar to log P, so the higher the log D, the more diffusion, the more lipophilic. Okay, but the actual plasma level you can get a prediction of, and I know you can't read it here, and I apologize, but I had to kind of fit it on here. But you can actually get the amount of drug dissolved, and then the amount of drug absorbed is in the bottom here. Okay, so you don't need to know much about that, but just understand that there are programs out there that will do all these predictions for you if you insert the appropriate drug information. Okay, and this usually is just assuming that it's normal physiology. If someone has a normal GI tract, right? You could modify that if you wanted to. You could say, well, what if someone didn't have a jejunum segment 1 or the first part of the jejunum, if that were resected or removed, the absorption should disappear there, and that's what the program would reflect. So you could modify the geometry and other characteristics of each part of the GI tract, and that will give you, first of all, a difference in absorption in that region, and then the overall absorption might change for a real drug. So you can make these predictions, and they do that in drug companies, like I said, and also the government. And this is the actual, just the plasma concentration profile of furosemide. Okay, down here, this was the dissolution and the absorption. How much is absorbed over time, and this is the actual plasma concentration. Okay, over time. So all these things are just predictions, and a lot of them are pretty accurate. So you could basically, if you were in a drug company, you can say, well, if our target blood concentration of furosemide is X or Y, whatever it is, in order to achieve that, this model tells me that I have to start with a dose of this or that. So that's the whole point, is that you can play around with it and try to come up with an appropriate starting dose for a clinical trial. Now, most of you will never have to do that, right? Because you may not be working in drug development, or you never know. I mean, you never know if you're going to diversify in your careers, but I just wanted you to be exposed, at least to be aware that this stuff can be done out there now, that there are programs to do most of the work, and most of the equations they're already embedded in the program. So that completed the bottom-up approach. The main thing I wanted you to take home, because you might be asking, well, what do you actually need to know from that? The main point for the bottom-up approach is that it takes into account the individual physiology of each part of the GI tract, and things like transporters and things like that can be incorporated into the pharmacokinetic model. And that's the main point, right? That it has more detailed information on each part of the absorption process. So the advantage is that, again, it's flexible, and you can extrapolate to diverse populations without generating new data, and still get a somewhat reliable prediction of the absorption. The top-down approach is, again, more standard, and that's going to be looking at going right to the plasma levels without knowing the detailed organ physiology related to that drug, like how is it absorbed in each component of the GI tract, and what transporters handles that drug. Well, we're not actually looking at that in the top-down approach. We're starting with actual just blood level data. So that's more traditional. It requires administering the drug to a set of patients to generate the data for the model first. So you need to get experimental data before you could actually generate a model. In every case, software is going to be used for these models and the other models. Again, but the detailed information on each organ is not required. So the remaining slides will, this whole presentation will really be a discussion of the top-down approach from this point on. So first of all, just like elimination, absorption could be first order or zero order. So if you understand what first order and zero order means, then it'd be pretty easy then to understand what that absorption process would look like in either of those cases. Okay, so most drugs actually follow first order. That means if you have 100 milligrams of drug in the intestine and 10% is absorbed per hour, well, let's just say per hour, which is probably really, really slow, but we'll just say, for example, 10% is absorbed per hour. So in the first hour, it's 10 milligrams. The second hour, you only have 90 left, so it would be 9 milligrams, right? The third hour would be, what would that be, 8.1 or something milligrams. So the whole point is that the mass absorbed per unit time changes, but the percent per unit time absorbed is the same, right? Just like elimination, it's the exact same thing. Okay. So obviously, if you increase the dose, you'll have more drug available for absorption. So the mass absorbed per unit time will be faster at first, right? But the by definition, if it's a first order process, the fraction absorbed per unit time should not change. Okay, so zero order is very rare. It means regardless of the dose, we'll always see a constant mass absorbed per minute. So if I give someone 10 milligrams, if I give them 100 milligrams, we still get, for example, 10 milligrams absorbed per minute. Again, that's really, really rare because that would imply that you've saturated the absorption, all the absorption processes, which is very difficult because there's such a large surface area in the GI tract. It's very unlikely to saturate all those with drug. So I wanted to start off with kind of a basic idea here, and really just discussing what determines the rate of change of the plasma concentration. So what we're going to do is kind of dissect each phase in oral absorption. We're going to dissect each phase of that. So remember, if something's not given IV and it's given orally, we're going to have a gradual increase in the plasma concentration. It will reach a peak, it will decline, but then in most cases, after it declines, then we'll have a shift. We'll have a shift at some point where we go from the post-absorption phase to a purely elimination phase. And I want to clarify something here. When we were talking about IV administration, we said that any inflection point, we said that meant there was at least 2 compartments. Well, that rule does not apply here because basically what we're seeing is while we're getting absorption, slow absorption, right, we're also getting distribution. So the whole point is that distribution phase is not instantaneous here, okay? Because basically the distribution is occurring as we're slowly getting more and more absorption. Okay, so let's not worry about that too much right now, but let's get into the rest of this slide. First of all, the rate of increase in the plasma concentration is not only based on the absorption rate, but is also based on the elimination rate. So just think about that. I mean, as soon as a single molecule of drug is in your blood, right, it has a chance of being excreted or eliminated, right? So the body doesn't separate absorption, distribution, and elimination, right? Once a drug is in the blood, okay, once any drug is in the blood, it has a chance to be distributed or eliminated, right? And remember, not all the drug is going to be absorbed at the same time. So as you know, we've already found some in the blood, right? Some's getting in the blood. Some is already, you're not going to see it on this graph, but some of it's already getting eliminated during this absorption phase, right? All you're going to see is, right, the outcome or the final or net concentration in the blood. But actually during absorption, we also have elimination, right? So keep in mind, we always have elimination once the drug hits the blood. All right, and that's what that second bullet is emphasizing. So what causes this hump or this peak, okay, in the early portion of the curve? That's actually a balance between absorption and elimination. So as soon as the absorption rate equals the elimination rate, we get a flat, not really a flat point, it's basically a peak in that drug concentration. So that hopefully that makes a lot of sense, right? And it's actually, to be fair, it's a combination of absorption, distribution, and elimination. So once the drug absorption rate is equivalent to the rate at which the drug is leaving the blood, right? It's entering the blood and leaving the blood simultaneously. Once those rates are equivalent, we get a flat point there, right, or a peak at that point. After that, it's called the post-absorption phase. That's a misnomer because it doesn't mean there's no more absorption. It means that the drug is leaving the blood faster than it is entering the blood. It means there's still some absorption, but the absorption is slower than the elimination at that point. And when I say elimination right now, I'm talking just removal from the plasma. So it could be distribution, it could also be elimination by the kidney or the liver, or any other organ that would do that. So Just keep in mind that absorption is still occurring all the way until we finally get to the elimination phase. Okay, and again, elimination is always occurring once the drug hits the body. Right. So none of these are really, for the most part, you don't want to consider these absolute, like this is only absorption and this is no absorption, or this is only elimination. For the most part, these are a combination of things. This is always, the absorption phase always has absorption, distribution, elimination. The post-absorption phase also has absorption, distribution, elimination, but the absorption is a little slower here than the elimination. Now the elimination phase, yeah, that means the absorption is totally over with, it's totally complete, but we still have distribution back out of any tissues that have a slower distribution. Okay, so the main point is that you should understand why we're getting a flat. Sorry, I think the last slide got cut off. My voice did. So all I was saying is you should understand all the processes that are occurring at each phase, right, of this graph here. So understand the processes that are occurring at each phase, and which ones are dominant and which ones are less active during each phase. So mathematically, this is a simple expression. This might look like some kind of complicated math, is really not, or some kind of strange expression. It's really simple. So all this is saying is that in the absorption phase, the change of drug in the GI tract, that would be the mass of drug, right? The change of the mass of drug in the GI tract over time is greater than the change of drug eliminated per unit time. All that's saying is the absorption rate is faster than the elimination rate, right? So there's more drug appearing, leaving the GI tract and appearing in the blood than there is drug leaving the blood or leaving the plasma and going out to the excretory tissues. So that means leaving the GI tract, entering the plasma is much more rapid, because of course there's all the drug in the beginning, all the drug is in the intestines, right? So that's going to push it much more quickly into the blood, and the blood is just starting to see it, right? We're just starting to see a drug there, so that's why this is the absorption is dominant there. Like I said, at the Cmax, the absorption, which is it's also expressed as drug changing or leaving the GI tract, right? That change in drug mass in the GI tract is equal to the change in drug mass from the plasma, which is considered elimination. D sub E is basically the mass of drug eliminated from the plasma, that is. Okay, so that's pretty much equivalent at that point. The post-absorption phase means drug removal from the GI tract, which is again drug absorption, is slower than the drug elimination. Or you can look at it the opposite way. Drug elimination is faster than absorption. So of course it should be going down, right? So that should make sense to you, hopefully. Right? So all this means is that the change in the plasma concentration is a function of the absorption rate versus the elimination rate. And remember, in this case, with these curves, when I say elimination, I'm saying just removal from the plasma, either into another tissue or into the urine or feces. So it's either elimination or distribution. But what I mean is getting out of the plasma, right? So if the drug is getting out of the plasma faster than it's getting into the plasma, that's the post-absorption phase. Okay, and that's the main point there. So I just want to briefly talk about the zero-order absorption model. I don't want you to memorize any of these equations, and I won't have you do these on the test because it's not really as common. But there are examples where someone would use this. And I mentioned that it's rare to saturate GI tract absorption, and that is true. But I just wanted to clarify that there's, in this one example here that I'm going to talk about, it actually is not super rare, and that's things like controlled release formulations or transdermal. So even though most of this lecture is going to be on oral absorption, I wanted to briefly mention that just in general, if you look at every different dosage form and not just oral, some of those dosage forms in general are meant for zero order absorption. So some of the transdermal patches are intentionally designed to administer a specific mass per unit time based on their design. So that would be zero order. And some controlled release oral formulations do deliver a constant mass per unit time. But we can model these actually with a pretty simple equation, and that would be down here. That would be zero order absorption, first order elimination, and that's a one compartment model. So we can actually combine, believe it or not, we can combine all these terms into a single equation to predict the plasma concentration at any time, and that'll be on the next slide. But let me just introduce you to each constant. Well, some of these are constants and some of these are just variables. So DGI is the mass of drug in the GI tract, so that will change over time. The K0, because again, that's a zero order absorption, that's going to be, well, that's a constant for absorption. dB is the mass of drug in the body, VD is the volume of distribution, and KEL is the elimination rate constant, first order. So what you're going to find when we get to the next slide is that the K0 is going to stand on its own. We don't need to know how much drug is in the GI tract in order to do this equation, because by definition it's a constant mass absorbed regardless of the drug in the GI tract. So I'll show you that on the next slide. So the equation is the change in the total drug in the body over time equals the absorption rate constant minus the elimination rate constant times drug in body. So the essence of this, and what I really want you to get from this, is that the elimination from the body, or elimination, in this case is from the whole body. That elimination is based on the drug present, the mass of drug in the body, right? So we have to multiply the KEL by the mass of drug in the body. Okay, whereas for KO, which is the absorption constant, we don't have to, notice we don't have the drug in the GI tract here. Even though we're talking about absorption, we don't have to incorporate that because this is constant. It's not affected, right? We're not influencing absorption rate by the concentration of the drug in the GI tract, because it's a zero order absorption process. Finally, I don't know if you remember, but the drug in the body can also be represented by the volume of distribution times the plasma concentration. That's the same as total drug in body. So we can substitute that, and if you wanted to get the actual plasma concentration, and I'm not going to ask you to do this integration, but you can actually get the plasma concentration, and that equals the K0, which is just the absorption rate constant, divided by the volume distribution times KEL times 1 minus e to the negative KEL times time. That would be any time after administration, right? Any time at all after administration, you can calculate the plasma concentration. I don't want you to know that equation, but I want you to understand the difference between zero order absorption and first order absorption, and in that, it means, mass versus fraction or percent. Okay, and that's the main point there. So now we're going to move on to first order absorption. Okay, and obviously that means a constant fraction is absorbed and eliminated per unit time relative to the total mass present in the GI tract or plasma at any time. So what that means is that when you change the amount or mass of drug in the GI tract, you will change the mass absorbed. When you change the mass of drug in the plasma, you will change the mass of drug eliminated, again, per unit time. So in this equation, we're going to need to, and this is not the elimination one yet, but we're going to get to that. This is just strictly absorption. So if we just wanted to strictly calculate absorption, how would we do that? So another way of looking at it, like I said earlier, is that we could look at the change of the mass of drug in the GI tract over time. right? So if that's going down, then we're getting absorption. So that would equal the negative Ka, so negative Ka times the mass of drug in the GI tract times the fraction, the total fraction absorbed. We'd have to determine that ahead of time, right? So only the total fraction that's going to be absorbed normally would be contributing to this. So I know it's a little strange or a little confusing, but basically what you do is take the typical fraction of the total absorption, and let me just add to that. That fraction absorbed is dependent on a lot of factors, but one of them is, if something doesn't get absorbed in the first, we'll say maybe 4 hours, it's past the absorption phase, and then it might be too far down in the GI tract to get absorbed. So one of the factors that are affecting the fraction absorbed is just the transit time and how slow the absorption is. So usually the fraction absorbed is pretty consistent regardless of the dose, to be honest with you. So that is a constant for the most part, especially in a first order process. But so let's keep that constant. You multiply that by the absorption rate constant, and then the mass of drug in the GI tract together. That will tell you how fast that drug concentration will change in the GI tract. Okay, so keep in mind, here's the only limitation, a big limitation, is that every fraction of every second this will change. The amount of drug remaining in the GI tract will continue to go down. So this whole equation would have to be recalculated, and that's why you integrate it, so you don't have to do that, right? Because that's constantly changing, that mass remaining in the GI tract. So the model would look like this. The drug in the GI tract is, the amount of drug removal is dependent on the absorption rate constant, which is first order, and then you have total mass of drug in body in the volume of distribution, and the elimination would be dependent really on the total drug in the body. Okay, so, and this is actually referring to elimination from the whole body. Okay, so next slide we'll see how that looks. Okay, if we're going to account for elimination, the equation is going to get a little bit more complicated. Okay, so the absorption equation can be used to calculate the change in drug mass in the body over time when it's combined with the elimination equation. So we could actually calculate first the change in total drug mass in the body, and then if we want to, we could convert that to plasma concentration once we know the volume of distribution. So anyway, if we go from this more simple equation and then we add the component, which is elimination here, that elimination factor, then we have a slightly more complicated equation. So it says that the change in the total drug mass in the body over time, it equals the fraction of drug absorbed times the absorption rate constant times the drug in the GI tract, the mass of the drug, minus the elimination rate constant times the total drug in the body. Again, if you integrate and combine all that, what you get for the final calculation would be, and again, I don't expect anyone to be able to jump from this equation to the final equation. I don't expect you to derive equations in this course, but the final calculation would be plasma concentration equals fraction absorbed times absorption rate constant times drug dose, that's the dose, DO, okay, and that's down here, over volume distribution times the Ka minus KEL, that times the quantity of E to the minus KEL times the quantity of time minus times 0, and all that means is, what is this? So what would be the lag time? Let me clarify that. So the T0 is the lag time after the dose until the absorption begins. So unfortunately, it's a little more complicated than we'd like, because once you give someone a drug, they don't absorb it immediately. The absorption starts after some lag time or delay. That has to be accounted for also in the equation. So the lag time would be that T0. So if it takes a half hour to begin absorption, you'd put, if that would be basically 0.5, 0.5 hours, or 0.5 for the TO. And the T is the time that you want to know what is that plasma concentration at that time, and we're going to stick with hours. So if I said, like, I want to know what the plasma concentration is at 5 hours, you'd put that that T is since the dose, so that's 5 hours since the actual dosing time or administration time minus the lag time. So what that does is it accounts for that lag time, so it doesn't unnecessarily add in that lag time, because the lag time has no absorption. So you're getting rid of that. You're subtracting that from this, because the actual beginning of absorption is after the lag time, right? So you would take that, and I won't read through the whole equation, but what you end up with is an elegant equation, a kind of complicated equation, but it tells you the plasma concentration at any given time, basically. Sometimes it's useful just to know the Tmax, predicted Tmax. So at what time does the patient have the highest concentration in their plasma? Could be very useful to know that. The only thing you need to know to calculate that is the absorption rate constant, the elimination rate constant, and the lag time. And every drug has different values for those, right? But they should be constant. For each drug, they should have their own constant. So Tmax equals 2.3 times the log of Ka over Kel divided by Ka minus Kel plus the lag time in hours. And that'll give you, again, how many hours it takes to reach the maximum plasma concentration. So as you can imagine, people aren't sitting there with a pen and paper or calculator doing these one at a time. All these have been incorporated into some very, like I said, very useful software that can do that for you. So I wanted to start off with a practice question before using the more complicated equation for plasma concentration, again with first order absorption and first order elimination. I just wanted to start off with the simple Tmax equation to give us a starting point with something a little bit simpler. So if we had an orally administered drug with the following constants, again all these would have to be predetermined through experimentation: a Ka of 0.91 per hour, a Kel of 0.08 per hour, and a lag time of 20 minutes, what would be the Tmax in hours? And I want you to do this first, and then what I wanted to do is say, well, if we know the Tmax, so how can we then figure out the Cmax? So we know that, well, we're going to know after this at what time do we have the maximum plasma concentration, and once we know that time, then we can go back and say, okay, at that time, what is the actual plasma concentration? So the Tmax equation is up top there. So all you're doing is plugging that in. So again, you're plugging in the values that we have right here. It's pretty simple. And the only thing you have to do is convert minutes to hours. So do that, and I want you to pause it now and work through that right now. And then right now I'm going to continue. So go ahead and pause it. All right, so I'm going to go ahead and reveal it. It's pretty simple. All you have to do is, again, mostly know how to just convert the minutes to hours. And what I got was, again, 2.3 log 0.91 divided by 0.08 over 0.91 minus 0.08 plus 0.333. Remember, 1/3 of 60 minutes, or 1/3 of an hour is 0.333 hours, which is the same as 20 minutes. That is 3.259 hours is the answer that I got. So you just always have to make sure your units are correct. And the reason why we knew that we had to be in hours, we knew that because the K values are per hour, right? If the K values are per hour, your times should be, any time on the equation or in the equation should be also in hours. Okay, so that means our Tmax, the maximum plasma concentration, should occur at about 3.259 hours. We've already accounted for the lag time, so that should be 3.259 hours after the actual dose is given. Okay, that should be after the real dosage time or administration time. So now that we have our Tmax for this hypothetical drug, I want you to imagine a scenario if if you decided to give 300 milligrams, if you knew for a fact that only 50% of the drug is absorbed, so you have 50% bioavailability, the volume of distribution is 12 liters. These are all kind of predetermined, so I had to give you that. What would be the Cmax in micrograms per milliliter? So again, I don't want you to get bogged down in deriving equations, but I want you to get familiar with, sometimes getting curveballs with units. Okay, so I said, first of all, the dose is 300 milligrams. What if I want to know the plasma concentration in micrograms per milliliter? We don't have to convert anything yet, but just remember, then whatever we enter into this equation will be the units that we get out. So we're gonna, if we enter 300 milligrams as the DL or the dose, and we enter the volume of distribution of in liters, that's fine. We'll start there. But remember, in the end, we're going to have to do a conversion if we really want to get to this answer here. Okay? Or we might have to do a conversion. I want you to think about if we do or do not, based on, what is a microgram? What does that look like compared to a milligram in terms of the times difference or fold difference? And what is a milliliter compared to a liter, or a liter there? So we may or may not have to convert the units, but sometimes we do. So I want you to think about that as you go through this. So everything else should be pretty easy. So the F is a fraction absorbed. It's a fraction, so you actually put 0.5. We already have the Ka, we already have the Kel, we already have the Vd down here, we have the dose, we have the lag time from the previous slide, and the only thing we need to think about is what time do we have to enter for the plasma concentration that we're looking for. Remember, we want the plasma concentration at the Tmax, at the time of maximum, the maximum plasma concentration. We already calculated Tmax, so we're going to need to enter that into here, the Tmax, and then the lag time as well goes into this equation. So let's go ahead and so go ahead and pause that and try it, and I'll give you like 5 seconds, and then I'm going to go ahead and reveal it. All right, I'm going to reveal what I have now in terms of work. So Cmax, again, 0.5 times the absorption rate constant times the dose over the volume distribution in liters, again, times the Ka minus Kel again. E is always 2.718. Of course, if you're using a calculator, you'll get more digits than that. And then minus, again, the Kel times, this is the power, to the power of the negative Kel times 3.259 minus negative 0.333. So notice we used our actual Tmax, and then we used our lag time here. Okay, so this first time is always the real time, the actual time after the administration that we want to know, that what the plasma concentration is. So what is the actual time after administration that we want to be measuring the plasma concentration, and that's going to be, in this case, I said the Tmax. Okay, and that's minus lag time, and then again, so on and so forth. We get the full equation. You should get something like this, kind of condensing everything. We multiplied top and bottom. I multiplied all the powers out. Okay, subtracted here and then multiplied. We got this, and hopefully got the same thing. Breaking it down, or sorry, contracting it a little more and finishing the calculation. And what I got was 9.88 milligrams per liter. And guess what? I might have lied, because the conversion, think about it, you actually don't have a conversion. So you just have to report it, though, correctly as micrograms per milliliter. But what I'm saying is, because a microgram, there's 1,000 micrograms in a milligram, and there's 1,000 milliliters a liter, the units automatically fix or correct for that. We don't have to change our answer. We just have to make sure we're reporting the correct units, right? Because this is 1,000-fold lower, this is 1,000-fold lower than respectively milligrams and liters. So 9.88 is our Cmax, right? And this calculation and the one on the previous slide, those are the ones that I would have you do. Okay, in fact, on the test, I think I'll stick with, my goal is to stick with, I'm sorry I say my goal, that's probably scary, like what if I don't actually do that, right? So I promise you it will be measuring Cmax and so from the Tmax, right? First calculating Tmax and then calculating the Cmax. So doing exactly what we did here with different variables. Okay, that I'll give you, like different dose, different fraction absorbed, different volume of distribution. And I can't promise you that I won't change the units. Okay, so you'll have to potentially convert them. If I say I wanted milligrams per milliliter instead of micrograms per milliliter. So remember, we already have liters, but if I wanted milligrams, we already have milligrams. So if I say, for example, I'm just trying to think of an example. If I say I want milligrams per milliliter, right? That would actually, you'd have to take this and divide it by 1,000 to get milligrams per milliliter, which is probably not useful because the number would be so low to plot on a graph or something like that. But I just want you to be prepared to potentially have to convert units. Something that I like to do myself on anything, anything, an experiment in the lab or something like this, is always check to see if it's, you have a reasonable answer, right? As you've probably all been trained to do in some of your other courses like calculations and things. So again, a simple check. I want to know, is that 9.88 milligrams per liter, is that something reasonable, or does it seem kind of out of this world and totally unreasonable? So one thing you could do, which I encourage you to try to do, is to determine if your Cmax, again, if your Cmax is lower than what you would have if you had zero elimination. Let me clarify that. The Cmax that we calculated in this, this previous calculation, that Cmax, remember, was happening, or that drug was being absorbed with simultaneous absorption and elimination, right? So the elimination, because some elimination is occurring in the very beginning, that will reduce your Cmax a little lower than if you had zero elimination. So what I'm saying is that why don't we pretend there's no elimination? Even pretend there's no distribution, right? There's nothing. The only thing there is really is absorption. So there's nothing else happening. If you had pure absorption and nothing else, that's a simple calculation. You take your dose. However, we said 50% is absorbed. We'll stick with that, right? We'll say that's not changing. 50% is absorbed out of 300, so that's 150 milligrams absorbed. The volume of distribution is 12 liters. So if we take 150 milligrams divided by 12, we get 12.5 milligrams per liter. So that's the simple check. It's saying if the drug was only absorbed and then untouched once it was in the plasma, we should get 12.5 milligrams per liter based on the volume of distribution. We calculated 9.88. So I think that's pretty good because it's saying that we're lower than, like, again, if we had no elimination or no distribution, which makes sense, right? We should be lower than that because in reality we have elimination and we have some distribution, right? So that makes sense. If our Cmax that we calculated ended up being higher than 12.5, right? So instead of 9.88, if we got like 15 or 20 or something like that, that would definitely mean we made a mistake, right? Because we can't have a higher plasma concentration than physically possible for the dose that we gave in the volume of distribution that the patient had. So the only thing that we could possibly see is the Cmax can get lower as we raise the elimination rate constant because some of that drug is getting pushed out of the plasma while it's coming in from through absorption. So hopefully that makes a lot of sense. And I encourage you to again always to check that. See, is it at least somewhere near where it should be? Is it at least a little lower? It could be a lot lower. It could be half of. We could have got half of 12.5 if we had a faster elimination rate, but it's got to be lower than that. If we assume there was no elimination or distribution. So I don't know if anyone here is familiar. I'm sure you've all heard of Excel, but if you actually use Excel on a consistent basis, but it's something I try to take advantage of. So I've actually put a lot of these equations in Excel, and it took some time to really figure out how to add the complicated ones and make them work well. But I got them working well, and basically I've taken the data that we just talked about, basically taken that, and then I've done automatic calculations on Excel to show what the curve would actually look like with our real data here. So again, we should see a delayed absorption onset because remember we put that that lag phase in. Then we should get rapid absorption, and then we should see a peak around 3.26 hours. And it should be, remember, it should be below 10. We said our plasma concentration, Cmax, should be less than 10 milligrams per liter. And that would be on the left there. That is an actual linear plot, right? So on the right, we have a log linear, which is considered a semi-log. And we got what we should get, which is the absorption phase. And then at some point we're getting the distribution, I'm sorry, the elimination and distribution happening together. And the whole point is that we should get a linear phase at the end, right? We have to get a linear phase at the end if it's first order elimination, and that's the main point. So remember, you convert it over to semi-log, you get, you go from, instead of a curve that kind of gets weaker and weaker in terms of slope, we actually get a constant line, perfect line on the elimination there. So this is the final slide, and I just wanted to end with a question because this will lead us to the next lecture. What would happen if we repeated the dose at a regular time interval? So this question could be for oral administration or IV bolus administration. Any repeated administration that's getting into the blood would be appropriate for this question. So if we gave the drug again before it was fully eliminated, that means there's still some left in the blood, and then we give another dose. If we did that for weeks or months, would we always reach a point where the patients had toxicity? In every case, would it build up, every time we gave it, would it build up higher and higher and higher and higher until it caused damage or crystallized or precipitated in the blood? Okay, so would the drug accumulate until it killed us or precipitated in our veins? Well, anybody here probably knows, right, that people do take drugs for years on a daily basis sometimes, right? And no, they're not, we don't have, like millions and millions of people just dropping dead from drug accumulation, right? So the answer is obviously no, right? But you might be asking, well, maybe everyone who gets a repeated dosing, maybe we are waiting for the drug to leave the body. So is that the answer? So are we waiting for the drug to leave the body 100% before we give another dose, right? And then it goes up and then it goes down to 0 again. Is that the answer, or is there something more complicated happening? And I'll leave it at that. I don't want to answer it because I think it's kind of fun to think about. Out of all the pharmacokinetic stuff, this for me is one of the more interesting things. So think about that, and on the next lecture we'll actually answer that question. Thank you and have a good day.